All right, I think we can benefit by introducing the councilwoman. We are lucky to have the councilwoman, Mercedes Narcisse, who has been a very strong advocate of Downstate and the health system in general. She came to say a few words and encourage us in the conference. So I'd like to invite you to say a few words before we continue.
I think it's afternoon at this time. No, it's still morning. Good morning. It's such a pleasure to be here in Downstate. My name is Mercedes Narcisse. I represent the 46th district, which is Canarsie, Flatland, Georgetown, Bergen Beach, Mill Basin, Mill Island, Marine Park, Garrison Beach, and Shipshead Bay. I have one of the largest districts in New York City and chair for a hospital committee. Let me tell you a brief story. The last time I was here, because before a hearing, actually, I was here to talk about Downstate, to make sure we keep Downstate alive. And guess what? We scheduled a hearing, me and the senator in the area, and we are able, from 40 million they were talking about, I said, 40 million for us in a Black nation in this area? We need the hospital, we need the services. 40 million is a joke. So let's start talking about the B. After the hearing, we took the hearing, and I received a call that they're moving forward. Just keep quiet a little bit. I said, I'll keep quiet when we get to the B. And then finally, the chancellor sent me an email at 7 o'clock in the morning, say, thank you, council member, we're reaching the B. So guess what? We deserve it, we earn it, and that's what we do as a nation. And I heard it earlier this morning. We have to hold ourselves accountable, whatever the space that we occupy. And first and foremost, I want to say thank you for this panel. Where's Dr. Paul? Dr. Paul took me, not only he took me to Haiti, I had the opportunity to bring my own child that had a vision to become a doctor. And from there, he became an orthopedic surgeon, and I heard the other doctor, Dr. Liverpool's daughter, become, I think, anesthesiologist. So that's mean what we do as a group of folks. I'm a registered nurse, by the way. When we took our heart out there to give the services and respectful services, the children were following, they were listening, and they had that passion and the compassion to serve as well. So it's a pleasure to be with you. Continue doing amazing things that you, wherever you are, amazing thing that you're doing. Keep on doing it respectfully, and the children will follow, and our nation will be better. Thank you so much, all of us together. Thank you.
Thank you. Thank you for all your support and for coming this morning. All right, so I now start the next session. We have 3 speakers for this session, focusing on kidneys. We're going to hear a lot about kidneys, kidney transplant medications, and the like. And we have 3 outstanding speakers. Because of the time issue, I would encourage the speakers to stay within the 30 minutes allocation so that we can finish in an hour and a half, and then be able to take some questions before lunch. All right, so I'm going to go into introducing the first speaker, Dr. Dinushika Mohottige. She's assistant professor of medicine and also in the Institute of Health Equity Research at Mount Sinai School of Medicine in New York City. She actually finished her bachelor's degree as a health policy. I didn't realize that. So she's actually a health policy expert before she went to medical school. And after that, she did her residency and then fellowships in nephrology. And now she's serving in this capacity at Mount Sinai Medical School. She's a rising star in the field of health equity research and also in nephrology. And today we are very fortunate to have her address a very important topic for us. And her topic is going to be, let's see. Yeah, her topic is going to be, I don't have your topic here, but she will tell us what the topic is. Ensuring optimal kidney health for all, the past, the present, and the future. So, Dr. Mohottige, please welcome to the podium.
Thank you all so much. It's really an honor to be here in community with you all, particularly in such an important, I think, political moment. And I have no disclosures to report other than I have had 2 NIH-funded grants defunded due to their focus on equity and racism. And I am speaking on behalf of myself and not the institutions that I belong to, which include the Bronx Veterans Health Administration. So just to overview, again, I'm a kidney doctor, I'm a health equity researcher. The majority of the work that I do focuses on structural racism and how it has, over generations, created some of the deep wounds that we see. So what are those? Just to kind of overview for everyone in the audience. In short, no matter what kind of underlying chronic condition we see, there are stark disparities. And so when we look at people who have diabetes, the incidence of developing chronic kidney disease among those individuals is significantly higher for Black, Hispanic, Latino, and Native Hawaiian Pacific Islander individuals versus their white counterparts. And this is fairly recent data from 2022. Many of you know, I think one of the most important things that's happened for the field of kidney health and prevention is considering cardiovascular, kidney, and metabolic syndrome together as one entity, recognizing that we need to prevent this very early at stage 1 of disease. What is critical to recognize that even though this term CKM syndrome was coined fairly recently by the American Heart Association, a lot of the preliminary data that we have shows that racial and ethnically minoritized people and men have a greater prevalence ratio of advanced cardiovascular kidney metabolic syndrome versus their white counterparts. So we have a huge amount of work to do. And when we look at the kind of trend of disparities over time, we have had people in this country describing and trying to tackle this issue for over now 2 decades. And we are still talking about the same disturbing stark inequities in the burden of kidney failure in particular. So what you're looking at here is the fact that essentially the prevalence of kidney failure in the United States, particularly in the last 5 years, has not really moved. And Black individuals in the United States continue to have a persistently 3- to 4-fold higher chance or incidence of developing kidney failure versus their white counterparts. And many people have tried to say, okay, there's genetic components, et cetera here, but we know for a fact that that has never fully explained all of these disparities. So what does? It is the care that we have provided, but more specifically, the structural inequities rooted in racism that have created a lot of these longstanding disparities. So this is a disturbing one that we should all pay attention to. Racial and ethnic disparities in the receipt of 12 months of nephrology care with a nephrologist not only did not improve between 2005 and 2015 among people with end-stage kidney failure, but they actually got worse. For all racial and ethnic minority groups. This was outstanding work done in Baltimore. And we know that this is critical because getting earlier access to us as nephrologists often means we can start to plan for things like kidney transplant, prepare people for vascular access, and all of these things earlier. This is a study from Baltimore that I did in part with my longtime mentor, Dr. Ebony Boulware, whose primary study it was. And what we showed is that Black individuals, women, and people who made less than $20,000 a year were less likely to have a conversation about transplant versus dialysis, despite the fact that we know that transplant confers better mortality, morbidity, quality of life, and cost savings. So we have a fundamental issue with the way that we are talking to our patients about certain types of opportunities and benefits and talking to some groups versus others. There's a clear bias in this pattern, particularly in this Baltimore study, but also nationally. And what about this idea of pharmacoequity? So this is the idea that everybody who is eligible for a disease-modifying therapy, so things like SGLT2 inhibitors, RAS inhibitors, GLP-1 receptor agonists, things that we know now are slowing the progression of end-stage kidney failure, we should all be able to get the patients who need these on these at the right time. And we know our systems are unequal, and insurance, for instance, is a huge contributor to the fact that, you know, some of those inequities are unequal. Is this better? Okay, all right.
Saying like the P sounds just
Yeah.
directed above the microphone.
Okay, Okay, all right. So what this study showed was that in a VA system where ideally we should have all of our patients, right, getting the same kinds of access to these novel therapies, even in this VA system, the amount of prescribing of SGLT2 inhibitors, which now really are kind of gold standard care for most of our patients with chronic kidney disease, this is low. But what is very disturbing is that the odds of prescribing these is significantly lower for Black versus white patients, for women versus men, and there are huge variations even within the VA system. This is just a snapshot of what is happening. This is focusing on the VA system, but this same sort of lack of pharmacoequity, so lack of people getting the appropriate therapies at the right time for the right populations, has been shown in multiple studies across people with Medicare and other types of insurance as well. And what about transplantation? So you're going to hear more about this from our amazing colleague, Dr. Watkins, later. But what is, I think, critical to recognize from a general nephrologist perspective, for the majority of people with kidney failure in the United States, getting a kidney transplant from a living donor is really the thing that confers the best long-term outcomes of that kidney, the best cost savings, the best morbidity, the best quality of life. And yet, for decades now, we have seen a dramatically lower odds of receipt of this life-saving optimal therapy, particularly for Black Americans versus white counterparts, but also for other racial and ethnic minority populations. And these disparities have also widened. This is also amazing, groundbreaking work from colleague Dr. Tangela Purnell at Hopkins. And now I've started to give this talk in the context of how do we get this message across to the country so that everybody cares, not just the people directly and most dramatically impacted by this. So I show this slide as a reminder for white Americans. We are not doing better in this country for white Americans versus white counterparts in comparable OECD middle and high income nations. And this is a critical point. So US life expectancy at birth remains lower in the US for white Americans versus all of our kind of counterparts in these wealthier countries, despite the fact that we are spending more in terms of our overall gross domestic product on healthcare. So something has got to change structurally. This is costing people lives, and white people in particular who may perceive that some of these anti-DEI efforts are improving their health, they are not in fact doing that in any way, shape, or form. So we have to correct that narrative. What are other kinds of dramatic contributors to some of the disparities we have seen? Many of you remember that for years we have been using race-based equations to determine people's kidney function specifically. And what this picture shows you is some of the educational material that was given by the National Kidney Foundation to many patients. And it shows that for these three people with the same exact biomarker that we use to measure kidney function, serum creatinine, they would have had a totally different estimation of their kidney function because of the prior use of Black race coefficients in kidney function estimation. This caused an enormous amount of harm, and I'll touch briefly about that later, but what I want you to notice is that one of these people may have never even had a screening for albuminuria or proteinuria, this young man who's 22 years old, despite the serum creatinine of 1.2. And yet the 80-year-old white woman on the figure would have been probably referred to a nephrologist with this kidney function that's estimated at 46. So this is the kind of structural clinical algorithm-based inequity that was rooted in some of the disparities that we saw. And what were the harms of that? Many people in the country spent several years documenting the harms before we saw a national change. This is a critical thing that everybody in the audience should know about because it impacts all of the people that we see. Our patients should be empowered with the knowledge that in the current day and age, and the standard of care should be that race-based kidney function estimations should not be used because they systematically overestimated the kidney function of Black Americans for years. We, based on national studies, an estimated nearly 1 million people would have been eligible for therapies to slow the progression of their disease. 1 million Black Americans. An estimated 70,000 people would have had a kidney function estimation significantly lower, less than 30%, who would have needed education about living donation. And the estimates before the national change in 2021 suggested that removal of this race-based coefficient would have resulted in a median reduction in 1.9 years of waiting for a kidney transplant. So dramatic, dramatic impact of this race-based algorithm. And what is really startling is that it's not new that we're talking about the problem that perceptions of race as a biologic reality have had in our society. Way back in the 1950s, UNESCO said that this idea that race is a biological reality has created an enormous amount of human and social damage, and yet it is only in 2021 that this equation changed in the United States nationally. This happened because of, again, many years back in the Enlightenment era, we created these classification systems around race that really had nothing to do with biology or genetics, but really tried to classify people based on all of these phenotypic characteristics. And this was all part of a very systematically ordered, politically oppressive system created really with an underpinning of racism to create hierarchies. That got translated into science and into clinical algorithms, which we need to continue to combat when we see them. And if that still hasn't convinced us all, right, that race is a kind of a socio-political myth in this United States context that's used to create quite a bit of systematic disadvantage and harm, all you have to do is look at the US Census maps to see how many times we have changed the way that we categorize people in the United States. There was a time period when we didn't even have some of the categories that we do now, and we'll touch on that in a little bit. So what progress have we made? I think this was already alluded to, that in 2000, we, for the first time, due to the very public murders of so many Black Americans, we had almost a revolution of sorts, and we made quite a bit of progress. I think one critical piece of progress, this is a perspective that colleagues and I authored, was in response to the changes made to remove the Black race coefficient. What is really incredible is that not only did the equation change, but thanks to our transplant colleagues and all of the people who advocated nationally, for the first time in US history, this was a restorative policy that was put into place by the transplant organization to make sure that Black individuals who were harmed by the prior race-based equations could actually get their time back. So all transplant centers were mandated to essentially use the new equation and sort of provide time back to all of these individuals who are harmed. And this resulted, at least to date, estimations of nearly 18,000 or 19,000 Black individuals have had wait time modified with a median wait time back for them of 1.7 years. So a big victory and an example of how research can translate to policy with a lot of advocacy from patients as well. Other things that have been great examples of progress, the way that kidney donors' organs were graded also used to be graded based on a Black race coefficient. And thanks to the advocacy and scientific rigor of a number of scientists, that was fortunately removed from the way that these different kidneys are graded using the KDRI. So we now have a more accurate way of doing this work. But we need to continue to forge on and identify other examples of clinical algorithms where race-based medicine has infiltrated and continued to create systematic inequality. There's also wonderful, I think, examples of policy changes that have occurred thanks to the advocacy of patients and many people who partner with the National Kidney Foundation and other organizations. So We have, for example, immunosuppressive coverage now for the long term of a person's kidney transplant for people who have Medicare. This was due to a tremendous amount of advocacy. Now all of us who take care of dialysis patients have to complete a social needs questionnaire for all of those individuals we see. Hopefully, we will have some resources to actually support people to meet their social needs, but even embedding these questions into the CMS forms was a big victory, and we need to do more. But there are still structural inequalities that we have to tackle as well. And we do know that neighborhood conditions contribute quite a bit to some of the dramatic inequalities we see. This is some very early formative work that shows that the neighborhood that you live in and the poverty within that neighborhood is actually associated with a higher risk of kidney failure for both Black and white patients, right, in the United States, though that gradient of impact is higher for Black Americans. We know that when we talk about access to kidney transplantation in particular, no matter where you are in the country, even though this study is focusing on the Southeast, no matter where you are in the country, most social workers, dialysis nurses, and dialysis clinicians will say the biggest barriers to our patients getting kidney transplants, they are largely very similar. Transportation, understanding, a lack of being provided the appropriate information and education about what options are, distance, and socioeconomic factors. So we need structural solutions to address all of this, and we need investment. There were so many beautiful talks earlier this morning about the role of the language that we use in our medical charting, and I wanted to highlight this study. I hope this can be done in some of the nephrology and other sort of subspecialty spaces as well. But this study highlighted that a review of the electronic health record from a Chicago hospital system showed that compared to white patients, Black patients had 2.5 times the odds of having at least one negative descriptor in their notes. This is unconscionable. And we have to hold each other accountable, hold our colleagues and our systems accountable for creating some change. The way that we write about our patients has such a profound impact on the journey that they have, particularly around things like kidney transplant. And back to that point about how we villainize patients, right? In the medical chart, a lot of people say, oh, this person is showing up late to their dialysis treatment. They're not a great candidate for transplant, or they're not a great candidate. They're not adherent. I want you to take note of this quote from a patient who is talking about the challenges that transportation has caused to getting to dialysis treatments on time. Sometimes I have to sit and wait at least an hour, and I have to call and say my ride isn't here yet, which makes me late getting there, which makes me late getting on the machine, and then coming to pick me up then if you're not ready, and then I just wait and wait and wait. This is already after an exhausting, often 3.5 to 4 hours of being on dialysis 3 times a week for the people that we take care of. And 84% of nephrology social workers said that public transport leads to shortened treatments. So when we think about adherence, we have to think about the root cause, and we need structural solutions to fix these root causes. What are some of the other structural inequalities that we have? And a lot of this is rooted in structural racism. We know that the Flint, Michigan water crisis is just one of the many examples of environmental inequity and how that can impact health. There are inequities in access and delivery of care, in psychosocial distress, and the traumas that we are exposed to differentially depending on the communities that we live in. There is targeted marketing of health-harming products like tobacco and alcohol in certain communities. And then certain communities we know have systematically been disinvested in, not only in the periods of redlining that go back to the 1940s in the United States, but in the present day, through present day policies and practices. And then there is a range of other ways in which more sort of upstream factors like voting, housing, education, criminalization and policing, and economic factors impact health. We wanted to study this. I used to live in North Carolina. I lived there for 21 years in Durham, where I was fortunate to be able to do this study with colleagues. We wanted to test this hypothesis that structural racism is fundamentally linked to chronic diseases. What you're looking at in this picture is a picture of redlined Durham from 1950. There are maps like this for every single city in this country, including New York City, that show how housing policies from the 1940s and 50s created restrictions and disinvestment in certain communities where primarily Black and brown people lived and poor individuals lived. And over time, that carried on through, again, lack of resources and other things. And we hypothesized that that would lead to chronic disease prevalence that was greater in those communities. What you're seeing below that is a racially restricting covenant from 1950s in a certain neighborhood in Durham, which says no property in this neighborhood shall be sold, conveyed, rented, or leased in any part to any persons who are not of the white or Caucasian race. So this kind of policy created the neighborhoods that we see in different parts of the country. And we wanted to focus on Durham as an example because it's heterogeneous, it's socioeconomically heterogeneous as well. And we had this amazing ability to conduct this study because we had the electronic health data on chronic kidney disease, diabetes, and hypertension from all of the people who lived in Durham County, who went to Duke Health in our federally qualified health center, and we linked this to all of this socio-contextual data that you're seeing here. So we were able to link it to data on evictions and housing and police shootings and a number of other types of factors. And I want to highlight between two neighborhoods how differently things can kind of pan out. One community here you see is redlined or historically redlined, a community called Hayti, and the other was not. You see how different the kind of proportions or demographics of the people who live in these communities are, but I want you to take particular note of not only the almost 4 times higher median income in the non-redlined community, but also what is going on in these communities. So one has almost 100% of the homes are near fast food stores versus 10 to 15%. And you see even in terms of primary election voting, in one community almost 60% of people are voting in the primary, and in the other almost 12%. And so we hypothesized, again, this is due to criminalizing laws that continue to support felony disenfranchisement and other modes of essentially restricting voter rights. So all of these different policies are manifestations of structural racism and do ultimately have an impact on kidney disease. And that is what we found in this paper, that for every single way in which we conceptualize structural racism with these disadvantage metrics or with specific examples of structural racism, each one was associated with a higher prevalence of chronic kidney disease, type 2 diabetes, and hypertension in this one single county. What about the kinds of products that we know exist in our communities that may cause harm to patients who may not, or people who may not know that they have kidney disease, particularly over-the-counter pain products? I was particularly interested in this question because in Durham, North Carolina, I saw many people just like this gentleman, 52 years old, 14, 15 years of diabetes, high blood pressure, had macroalbuminuria already, said that he wasn't using ibuprofen and all of this, but had horrible back pain. And he said, I'm using these headache powders all the time. I would have to, unfortunately, like many of my colleagues, do dialysis on some of these people who are coming in after this headache powder ingestion. And but this is just one example of something that's on the consumer market, right, that a lot of people are not aware of, non-steroidal anti-inflammatories, where there are differential patterns of the use of these medications, but they may be very harmful in people who have chronic kidney disease. And this particular product, sold as BC Goody and Standback powders, each powder pack has 500 to 1,000 milligrams of aspirin. Very few of the packs have any warning about kidney health on them or any warnings about even cardiovascular health or high blood pressure. And when we started to look in stores in Durham, North Carolina about how they were being marketed, we noticed a lot of different marketing techniques, fast and best, those kinds of words being used, and they're sold at a lower price point than even ibuprofen or Tylenol. And we hypothesized again that this was causing disproportionate harm because people we know of lower socioeconomic status are much less likely to have well-controlled pain than people of higher socioeconomic status, and the same thing for racially minoritized people. So to test this hypothesis, we took data from the Nielsen database, which checks what all kinds of people around the country are purchasing. And we proved our point that these products are not only sold they're more prevalent in terms of their sales in the Southeast, where the belt of chronic kidney disease is greatest, but also that Black households in particular versus white households and households with income less than $25,000 were more likely to have purchased these products. This was a really, really important kind of finding, and what we hope, I know this is not showing up well, but what we hope is that this can lead to some changes in terms of the way that we are empowering people who are consumers about the products that they are consuming. And so we can talk about things like racialized marketing and provide some more consumer protections. I want to close in the last just few minutes here about what is at stake now and where we must go. What is at stake now is grave. I already discussed the fact that race-based clinical algorithms have caused a disproportionate amount of harm in the United States. What you see here is one of the executive orders that is trying to dismantle a lot of the kind of cultural and historic monuments that we have, including at the Smithsonian. This particular sculpture was part of this executive order. And what you see here in this language, right, is highly, highly concerning. This executive order didn't even really make it into much of the media. But what it says is this exhibit claims that this sculpture promotes scientific racism. I already proved that scientific racism exists. And it promotes the view that race is not a biologic reality, but a social construct. How incredibly disturbing is this? So we have to counter these harmful narratives and show examples that for decades now we have proof that, again, race and ethnicity is a flawed surrogate for a number of other factors, and we have to move toward precision and understanding genetics and really disentangling racism from race. And I've already showed you again that we have examples from the census that, this is a lot of made up stuff that we're doing. And another great example of how this was embedded, right, for years. Look at this 1947 article where they're saying sickle cell anemia is a race-specific disease. If we really thought that, we would not even be able to detect sickle cell trait or sickle cell anemia in many millions of people in the world who are also impacted by sickle cell trait and sickle cell anemia who live in, for example, the Middle East, right? So it was scientific discoveries that showed that this is a geoevolutionary adaptation that resulted in this gene frequency. And just like that, we have other new kind of genetic discoveries in kidney disease. It is APOL1, specifically a particular protective genetic variant for African sleeping sickness. There was a time period when, people were saying, okay, we should only focus on people who self-identify as Black for testing for this. But in fact, there are many people who self-identify as Latino or Caribbean American who have APOL1 specific traits, and Native American, who, if we had just a race-based idea of this disease, we would really be causing harm and missing screening and critical opportunities to provide them care. We also need to understand some of the second hits that accelerate disease, such as structural racism. And that's actually what one of my studies was trying to test. But we got this notification from the current administration that this award is related to DEI and it's antithetical to scientific inquiry. This is the language that many of us who've had defunded NIH grants have received. As you can see, it is incredibly painful to read these words. It is damaging, it is untruthful, and I have a patient and community stakeholder board that was part of this particular study, and the night that we got this termination notice, we all read this together. And every single patient on that board said, this reads to us like we do not care if you die. So what actions do we take now? We have to have hope. And I think we need to provide more counter narratives to those who continue to say that there is a fixed pie. This equity is not a zero-sum game, and this book does such a beautiful job of, I think, highlighting this fact that, again, zero-sum thinking is causing a lot of harm. The fixed pie fallacy thinking is causing harm, and when we ensure equal opportunities and resources for those who are the most disadvantaged, we improve systems and outcomes for all of us. The second thing is we have to continue to connect the dots. So as we see Medicaid funding cuts, it is not just those of us here in this city who will be impacted, but many of our colleagues in rural parts of the country where, again, the kind of largest populations are not necessarily racial and ethnic minority people. Rural hospitals will shut down, so we need to start building coalitions with people around the country. We need to start being very clear about what these cuts are going to do for the people that we take care of. So this is a slide that is very specific to people with kidney disease. But just a reminder that before dialysis, nearly 1 in 3 people who have kidney disease rely on Medicaid before dialysis. So this will be devastating. And then we need to start to cite the facts about what this is costing us in dollar amounts. This was a really important, groundbreaking study showing that the estimated total burden of racial and ethnic disparities in healthcare cost a total of $451 billion nationwide, with a disproportionate burden, again, on all racial and ethnically minoritized communities. We have to, in our charts, start to do better with the way that we're documenting. So every time we're writing in a medical document, we should be asking ourselves these questions. Are my reinforcing stereotypes? Is this blaming the patient? Is there extraneous information? Is it biased or harmful? And how would my patient or loved one feel if they read this? We need to continue to support efforts such as Medicaid expansion and waivers that offer opportunities to fund community health workers. We need structural solutions for these community health workers to help us do our job and the critical job of navigating patient journeys better. These are just examples of things that, again, community health worker interventions can really help us address each of these domains. And then we need disruption. This is actually a former co-fellow of mine who started this program in Michigan, where they have people in the community taking medications to patients who need transplants and driving them through, again, faith-based organizations and partnerships, driving them to the transplant center to get their initial evaluation appointments. So even when these NIH funding cuts happen, we can still do the work we have to do. We must do the work that we have to do. And then partnered advocacy. This is me with many of the amazing patient community board members who are part of our defunded study, all of us speaking with members of the Senate Help Committee, talking about the devastating harm of that decision to terminate this study, among many others. So we have to partner to center and elevate the voices of our community and patient partners. I'm going to stop with that. Thank you all so much again for having me. I will. I wanted to leave with a quote, and lately I've been really, when people say that, there's voiceless people, or we're here to, speak on behalf of the voiceless, I think this is a reminder that there's really no such thing as voiceless people. There are only the deliberately silenced or the preferably unheard, as Arundhati Roy said.
Thank you.
Thank you.